So I started the recording. All right, so we're going to cover continuous positive airway pressure. This is really geared from EMT up. So if there may be some stuff that we already know about, obviously as medics and AEMTs, but this is for all levels. For those that are main providers, this does not count as of yet for the allowance for you to utilize CPAP in main. So there's another program the state wants us using, which is not this one here, for main EMS. So when that comes out, I think, Matt, you're the only one on the line right now that would need it. Other than that, EMTs and medics already have that protocol as standing order in the state. All right, so let's talk about continuous positive airway pressure, CPAP. So obviously with the goal, the student should be able to correctly utilize a service-specific CPAP device in a respiratory compromised patient. So when do we need to actually apply CPAP to these patients? And when we look at whether it be a COPD exacerbation to acute pulmonary edema, when does this patient require that continuous positive airway pressure that has that PEEP support? PEEP is like a crutch to keep the lungs open, and CPAP is kind of like giving somebody D10 or D50. You know, it's a life-saving device that can help reduce hospital time, admittance, and everything else. So again, CPAP is an important tool that we utilize in the field, and now with the paramedics and having ventilators on ambulances, we now have that ability to utilize BiPAP, which is even better than CPAP when you have the inspiratory pressure, which we'll cover a little bit more towards the end, looking at New Hampshire protocol for pre-hospital BiPAP. For the objectives at the completion of the training, the BLS provider and ALS will be able to describe respiratory anatomy and physiology, verbalize the understanding of respiratory disorders and illnesses, appreciate the benefits and limitations of CPAP in alleviating patient symptoms, and then indications and contraindications for the use of CPAP. So we'll do a quick A&P review. Obviously, looking at the airway and the respiratory system you see on this on the picture here in the slide. Nose, mouth, trachea, main stem bronchi, which then branches into the secondary bronchi and the tertiary bronchi into the bronchioles. And then with that, it goes into the alveoli. The diaphragm as a whole is the outside of the lungs, the full diaphragm here. All right. The important part of this, though, is remember, we need to make sure we're getting air in and air back out. So oxygen in, carbon dioxide back out, right? So with this, and we look at, this will actually tie into capnography when we get into the next lecture. We got to be able to support the alveoli and gas exchange. So if we take a breath in and we inhale air in as it's going through the oropharynx, nasopharynx, down through the pharynx, into the trachea, through the bronchi, the bronchioles, into the alveoli, right? And when it hits the alveolar level, that's when we're having our gas exchange. So the bad stuff's coming out and the good stuff's going in. Around and around the body it goes, perfusing cells, right? Without that oxygenation, we can't have good tissue perfusion, which then can turn into shock if we have bleeds or things like that. Or if we're not getting good perfusion at the cellular level, at the alveolar level, what's happening now is we're becoming more hypoxic. And this is where we're going to start seeing our waveform changes as well, especially if we have any kind of bronchoconstriction. And remember that when we see that shark fin waveform, even looking at the A&P stuff, that shark fin waveform that we're looking at is when a patient's alveoli are off-gassing at different times versus all the same. So we're seeing that shark fin kind of line versus the normal plateau that we're supposed to see. Everything off-gassing all at once when we breathe in and exhale. So that's what we're kind of looking at here. And our job is to help support that and provide a crutch to help open that stuff open, keep that stuff open. And that's where PEEP comes into play in CPAP. Remember that our system runs on a negative pressure. So respirations are driven by the process of negative intrathoracic pressures. The negative pressure initiates inhalation and acquisition of oxygen, which then assists to increase intrathoracic blood flow. Right, so the hemodynamic effects, I kind of explained that in the last slide. If we're having any kind of, let's say, away from CPAP, but if we're having, let's say, an internal bleed, or if we have bleeding, or if our patient's going into shock, we start seeing that tachycardia and tachypnea, right? So we see the increased respiratory rate, increased heart rate. Well, that's our body's way of compensating, so our compensated shock. In turn, our heart rate goes up to help circulate red blood cells, which attach hemoglobin and oxygen and everything else going through the cellular level. But also our respiratory rate increases because our body's like, we need more oxygen, so let's increase the respiratory rate. So if we have an issue with respiration, our body's going to try to compensate and make that change. So by increasing our hemodynamic effects, our heart rate goes up, our respiratory rate goes up, or have a higher oxygen demand. The goal is, though, is to equalize in pressure, which just initiates exhalation and elimination of carbon dioxide. So we're hoping, in turn, everybody takes the deep breath in and back out again, that we're having decent oxygen exchange, or alveoli are off-gassing all at the same time. Our bodily functions at the cellular level are exchanging at the capillary beds from the good blood to the deoxygenated blood from the oxygenated blood, and then it's passing back through the veins back into the heart, in the right atrium to the right ventricle into the lungs, and that's where our gas exchange is happening there. Looking at the bronchi and bronchioles, this is our cartilagic structure that give way to smooth muscles. This may divide up to 25 times before reaching the terminal bronchioles. So they talk about smooth muscles. So I'm asking another group, mostly paramedics, what medication do we give in a patient that's pending failure that helps with that smooth muscle relaxant to help the breathing process continue? What can we give?
Solumedrol or MAG?
Yeah, solumedrol as the corticosteroid, right? Then we have the MAG sulfate that helps with that smooth muscle relaxant to help with our breathing process. That's why it's so important to apply CPAP prior to even getting into this stuff here, because that's going to be the crush to open stuff up, and then we can follow with meds behind it. So the alveoli expand and contract while breathing, so they get bigger and it gets smaller, right? So with contact with pulmonary capillary beds for gas exchange, and is inside the surface coated with surfactant. So if we have a surfactant reduction, it doesn't help with that elasticity of the alveoli to get bigger and smaller, which therefore they will not be allowed to stay open. All right. If we have alveolar failure, alveolar collapse, it's called atelectasis. Excuse me. That's when we have a reduction in surfactant around the alveoli. When this is happening, we start having alveolar collapse, and then we have patients that end up having emphysema, bronchitis, or potential for even getting into something even worse than that if we have a completely collapsed lung for a pneumothorax. So we talked about the mechanism of respiration already. So obviously we take a breath in, it goes into the lungs, right? As it enters the lungs, it goes into the alveoli, which then gets oxygenated blood, then starts getting transported through the left atrium to the left ventricle out to the body. As it circulates through the body, our blood is then going through the arteries to the arterioles into the capillary beds. Into the capillary beds is where the gas exchange is happening. We have the oxygenated blood pushing oxygen out. Remember, it's a gas, so it's through diffusion. And that is being diffused into the capillaries, where we start oxygenating the cells. As the waste products are being discharged out, it's going back into the deoxygenated blood through the venules into the veins. As that circulates through, it goes back into the right atrium, into the right ventricle, into the lungs. Now, obviously, I missed a couple things more at the paramedic level of how that flows, but that's more of the baseline of how it's supposed to work. So as blood follows through, we have to make sure we have the adequate exchange. But if we can't exchange it due to alveolar collapse or off-gassing at different times, where we start seeing that shark fin or that bronchoconstriction, we've got to fix that problem, because the body is only going to take so long before it says, I quit. The patient goes into failure, and after failure, you go into cardiopulmonary arrest. So and then CPR will have to be started. So let's try to fix it at the earlier stages, and that's where that I mentioned CPAP again. That's where that crutch comes into play, or utilizing BiPAP. If you have Z vents on your ambulance, or if you have vents of any sort, BiPAP is 100 times better than using CPAP for any patient in the respiratory distress field when it comes to even pulmonary edema, because you have the inspiratory pressure and that expiratory pressure working together. So functional residual capacity, so lung volume at the end of normal exhalation.
Kevin, I got a question. For BiPAP on a truck, if we have a Z vent, is that a paramedic skill?
It is a paramedic skill only, yes. AEMTs and EMTs cannot use BiPAP.
Okay.
But 100 times better of a treatment if you have that availability.
Which we do.
Right. So muscles of respiration are completely relaxed. Okay, we still have that residual capacity that's there. We already talked about gas exchange and how it circulates through diffusion. Remember, it is a gas, not a fluid. There's a fluid via osmosis. It's a gas. So we're looking at the carbon dioxide, oxygen goes in, carbon dioxide comes out, and then it gets pushed out. So oxygenation is a process of getting oxygen to end organs and tissues. So kind of recapping what I mentioned before. We're looking at inhale through the lungs, picked up from the alveoli on the red blood cells. Red blood cells go through, hemoglobin attaches oxygen, and we start pushing it through the system. And then it is offloaded in exchange with carbon dioxide. Carbon dioxide comes back through, and then it's pushed out through exhalation. That's the plan. This is measured by pulse oximetry or SpO2, but you can't just throw an SpO2 on a patient and expect it to be accurate. You have to look for pleth as well. And in the carbon, sorry, my goodness, in the capnography class, which I'm going to do next, we will discuss the differences between end-tidal CO2 along with using pulse oximetry, and how these two in conjunction together can be a very good tool in the toolbox to help treat a patient. With that being said, and kind of like something else I want to add to it though, what other chemical that is out there or gas can attach to the red blood cells and trick the pulse oximeter?
Carbon monoxide.
Carbon monoxide, exactly. So we also got to look at other signs and symptoms on why this patient could be in respiratory distress and have 100% SpO2. So you've got to look at other signs and symptoms. And if you suspect carbon monoxide, obviously we have our meters on our bags, and therefore only personal safety. If you think there could be an issue with that, then contact fire to respond out and get readings of a home, just to kind of make sure. Ventilation is a process to eliminate carbon dioxide, waste products of an energy production, which is carried back through the venous blood, eliminated through exhalation. This is measured by capnography, which I said that we're not going to go into too much detail in this lecture here. As the next lecture, we'll cover this stuff more in detail. This is a normal waveform. As you can look at the waveform here, inhalation is down below. It should be a 0 reading. As we exhale, it spikes up, and then it plateaus off, and then your end tidal reading that you're getting is on this point where I'm circling with the mouse, if you guys can see that. All right. Then that's the last phase, well, second to last phase or phase 4 is the inhalation back down to level 0. That's the basics of capnography. We will cover, like I said, next lecture will be more detailed. We have A, B, C, D, E. So A, B, C. So inhalation, exhalation here, and then inhalation back down again. All right, so let's talk about some disorders. So a combination of many disease processes responsible for emergencies related to ventilation, diffusion, and perfusion. There are plenty that are out there, and a lot of these things that we can fix in the field. However, having the ability for rapid sequence induction, RSI, can make a huge difference depending on how bad the patient is, or if they can no longer maintain their own airway, or if BiPAP or CPAP is not working. So if you apply CPAP or BiPAP to a patient, you should see within 3 to 5 minutes there should be a change in their pulse oximetry. If they're not changing and they're still blue, then then the alveoli are not being oxygenated like they need to be. These patients need to be intubated at this point. And we're starting to see a lot of that now with COVID patients that are on BiPAP. They're not staying on BiPAP for long before they're being intubated and then being transferred to another facility if they can find somebody. And if you look at Maine Health System for Memorial, if they're on BiPAP, Maine Med is requiring them to be intubated now if they're on BiPAP for the transport because it's easier to maintain. So some of the disorders are respiratory distress. So subject indication of some degree of some difficulty breathing caused by either an upper or lower airway obstruction, inadequate ventilation, impaired respiratory muscle function, impaired nervous system, trauma, bronchitis, pneumonia, or cancer. And you can throw COVID pneumonia into that as well. So let's go back one slide. Let's talk about respiratory distress. So if I ask you guys, let's say at the AEMT level, Scott, what can you do to treat somebody respiratory? Just a quick down and dirty version of it. Anybody want to answer that? Let's say the AEMT level. What can you do for somebody in respiratory distress? Is anybody still there?
Sorry, I didn't hear you. Did you have a question?
I did. So
what
asking them at the AEMT level, if you had a patient in respiratory distress, not failure, what can you do for that patient?
Neb treatment.
Okay, so CPAP?
CPAP, non-rebreather, oxygen somehow.
Yep.
CPAP with either duo neb or albuterol.
Perfect. And if that's not working, then paramedics come on board. Then what do we have next for meds?
Solumedrol.
Yeah. So we have solumedrol or what was the other one? Sorry.
Nitro. Yeah.
Okay. So respiratory distress, nitro could be one of them. They're in acute pulmonary edema. We can utilize nitrates. So nitro.
Can you use them at the A level though?
Yes, you can. You can't use a nitro drip, but you can use nitro tablets.
Do they have to have a little bit of chest pain?
It's acute pulmonary edema. Well, let me admit, I think I lost Dave and all them again.
Thank you. Back in.
I heard Narcan. So let's just talk about respiratory stuff. So we talked about corticosteroids, right? Scott, you mentioned using nitrates. I believe it was you that mentioned that. And then we have CPAP, oxygen, things like that, right? So if we have a patient in respiratory distress, we have potential for, let's say, a COPD exacerbation. So obviously nitrates are not going to be given in that situation at all. We can use CPAP, BiPAP. Okay, this is looking at all levels, from paramedic down to EMT. EMTs have the ability to use BVM if they're pending failure. Okay, or if they need to oxygenate. If it's not working with a non-rebreather, we can put a BVM on their face and we can take it and administer a breath as they're breathing in with 100% oxygen. That's an option that we can utilize. If you're using CPAP or BiPAP, if you have the ability and able to get a good seal, put on nasal capnography, you can still get readings through it as well. And we have for medications now. So we have medications that we can utilize. We can either use dexamethasone or solumedrol. Dexamethasone is a better steroid for patients that have upper airway issues. Right. Solumedrol is a better medication for lower airway issues, lower respiratory. All right. And then we have the ability to go to MAG. What if MAG is not working? What can we do, medics-wise?
All right. RSI.
Epinephrine.
Oh.
We always forget that epinephrine is a respiratory medication. It's one of those things that we don't think about. We think of anaphylaxis, we think about cardiac arrest, but we don't think about respiratory distress. Okay, so we can give a dose of epi to help, obviously, vasoconstrict and help open up those airways.
Computer.
Okay, so that's another thing that we keep forgetting about. Other things of respiratory distress, if we have like younger kids, we can make nebulized epinephrine. We don't carry racemic, so we have to make it. So how do we make nebulized epi?
Epi with normal saline, right?
Right. So you take 3 mLs of saline and put 1 ml of 1 to 1,000 epi, and you can inhale that. That's your nebulized epinephrine dose.
Probably tastes pretty good too.
Oh, I'm sure it does. We'll put some flavoring in it too while we're at it. It's kind of like when you make a GI cocktail, people always add Donatol to it, so it gives it a little minty flavor. Just something else to think about, though, is we have the ability as medics to be able to do other administrations that we can utilize. So don't forget, another thing with RSI, the last thing we want to do is shove a tube down somebody's throat, right? As fun as it can be with medics, RSIing people and paralyzing and sedating, you have to know when it's the right time to do it. Not every patient needs to be RSI'd, right? Or even DSI for delayed sequence intubation. We don't have to do that every single time unless the patient needs it. Is there going to be a way for airway compromise, or is this patient in the position where they're not oxygenating with all the methods that we've tried? Are they in and out of consciousness? Are they in respiratory failure? Right. So that's the things we need to look at. Is there pink frothy sputum coming up from acute pulmonary edema? So those are the things we got to look at, and when the patient needs to have an RSI done, if and when we get to that point. So that's your respiratory distress. Failure, you'll start seeing often end-stage respiratory distress signs and symptoms would be tachypnea, obviously low heart rate, Brady, or apnea. Not heart rate, sorry about that. I mean low respiratory rate or apnea. And late signs, increase, decrease, or no respiratory effort at all. Tachycardia early, bradycardia late. Obviously cyanosis, you start picking that up around the lips first. And you'll start seeing more of like a central cyanosis as well, looking at around the chest, around the face. And obviously altered mental status due to the hypoxic levels can cause the patient to become altered, right? We want to fix it before we get into failure. That's why we have these availability of medications that the state has given us at standing order to make these treatments happen. And a lot of times just with CPAP alone and having that crutch or the bilevel pressures can make a world of a difference for these patients. Mechanisms of heart failure, frequently a chronic yet manageable condition where the left ventricle fails to work as an effective pump. If it's not pumping effectively, blood volume will then back up into the pulmonary circulation, most often caused by volume overload, pressure overload, loss of myocardial tissue, or impaired contractility. If we have left ventricular slowdown, so we have the work as an effective pump, that fluid will then back up into the lungs, right? So you're going to hear bilateral crackles in the lungs, and if you really want to impress a physician, you can do percussion sounds as well, looking for that dull sound versus a hollow sound. You can kind of see where levels are in the lungs as well. End-tidal CO2 works really well with these heart failure patients, and then on top of that, getting patients nitrates. So CPAP and nitrates right off the bat. Don't even hold off. So let's talk about CPAP in general when we apply this to a patient. How many times have you applied CPAP, and you guys can answer this question here. How many times have you guys applied CPAP and the patient starts freaking out? Has that happened before?
A lot.
right? It happens quite often.
Once.
Once for Dave. That's because, Dave, you have a trusting face and everybody loves you. So what protocol do we have that can assist with that?
Reduce their anxiety.
Anxiety protocol. Okay. So we have the ability to give somebody Versed or Ativan. All right. And it's not standing order. This is a med control order. Okay. You call med control and you can ask them for 2.5 of Versed. You can ask them for 1 milligram of Ativan if you have refrigerators or you carry Ativan on your truck. So you have that ability. Ativan is a phenomenal respiratory med. I always thought it would be. I always think it is because it reduces anxiety. If I can calm that patient down enough so they can maintain CPAP, then I think I've done my job. So don't be afraid to call med control. Even if you're 5 minutes out from the hospital, all right? A patient can go into failure in 5 minutes. It can happen. It can happen quickly, all right? So if you call the doc on scene and say, hey, listen, I got a patient trying to apply CPAP to their inability to breathe, their SATs are in the 60s, and they're not tolerating CPAP due to their anxiety. Can I give them 2 milligrams of Versed? The doc will most likely say yes. As long as you're not giving them enough to sedate them and just enough to bring down their anxiety, they're most likely going to say yes because it's a life-saving measure, right? And especially if you built a good rapport with the physicians at the hospital, you're most likely going to get whatever you call for. So to kind of recap this, don't forget about anxiety treatment because anxiety can be a hinder to your treatments as a medic or even as an AEMT, calling for a medic to come in to maybe help with that anxiety level. Pulmonary edema and cardiac and respiratory system is now fully impaired. This is an acute critical emergency where the lungs are now filling up with fluid. What's happening now is that you're now washing away the surfactant, which then creates pink froth in the sputum. If you have a patient coughing up pink frothy sputum, these patients here need CPAP right away. And or if you have the ability for RSI, if there's a lot of pink frothy sputum and their SATs are tanking, these patients need to be intubated quickly because we got to put that positive pressure into the lungs, pushing that out. Because just utilizing a BVM or CPAP, or if they can't maintain their own airway, CPAP is going to push that right down there, right back into their airway, and it's not going to be able to enough pressure to push that stuff out. What they really need is an intubation tube, and then just push it out, and then they're going to be given Lasix. Usually 40 or 80 of Lasix, depending on how bad the fluids are, to help piss it away. But what they really need is that positive and expiratory pressure. So you're probably going to see a patient on a ventilator with a higher PEEP setting on the vent. This prevents alveoli from expanding or significantly reduces or eliminates the ability for gas exchange to occur. Without gas exchange, patient starts going into shock and failure. Asthma is a reactive airway disorder, which is an exacerbation precipitated by intrinsic factors, characterized by reversible bronchial smooth muscle contraction, increased mucus production, and inflammatory airway changes. Persistent signs and symptoms can indicate tenfold increase in the work of breathing. So as you look at the pictures here, we have the normal airway with a little bit of mucus over here. Mucus starts to develop, causing complete airway obstruction. So evolution of the asthma attack is mucus thickens and accumulates, plugging the airways. Mucosal edema starts to develop. Muscle spasms constrict small airways. Breathing becomes labored. Exhalation becomes very difficult. These patients need bronchodilators, and bronchodilators fast. Okay, they got to open up these airways. So we can utilize albuterol. We can utilize Duonebs. We can give the 125 solumedrol, and then mag sulfate can also assist with this as well. There's been different studies that have been out there that said, yes, use CPAP, and no, don't use CPAP. Again, follow your local protocols for this. Use caution.
What's our protocol, Kev?
So our protocol, we'd have to utilize I want to make sure I read it exactly to the word. So stand by. I will bring it up. I don't want to. For some reason, I got Maine stuck in my head right now. I don't know why. This happens when you have to practice in 3 different states. Now it's stuck in my head.
CPAP is 5.4. What are you looking for, Kevin?
Well, that's CPAP. So I'm looking at 2.3A, asthma, COPD, and RAD, reactive airway disease. So they are saying CPAP for all 3. That's at the EMT level. EMTs start with CPAP for severe respiratory distress. Then we got to consider duo-nebs at the A level. We have methylprednisolone, dexamethasone, and then BiPAP for paramedics. So again, if you're on scene though, even with an asthmatic or any kind of COPD or RAD, if you're a medic and you have a vent on your truck, you should be going right to BiPAP. Honestly, that is the golden treatment. And if you bring a patient like this into the hospital and they have an asthmatic status asthmaticus, or those patients might actually get intubated, or if you have a patient in asthma attack, COPD exacerbation, they're going to put them on BiPAP in the hospitals. They're not going to utilize CPAP, right? Because they found that the bilevel pressures are way better for the system and can help oxygenate that much faster.
We don't have any vents on our 911.
We don't, not yet. Dave, I'm trying to stay positive here. Not yet.
Is that positive as in CPAP or positive as in BiPAP?
Right. I'm trying to stay positive that we're going to get those vents here soon. Hoping. Fingers crossed. So looking at asthma and anaphylaxis, you got to use caution with this. So causes of asthma would be smoke, dander, dust, pollen, cold air, mold, cleaning products, perfume, exercise. Anaphylaxis would be more like nuts, shellfish, milk, eggs, soy, wheat, insect stings, medications, latex. Don't confuse the two. Even though sometimes, even with asthmatics, epinephrine is still the treatment for it later stages versus anaphylaxis, where it's an early stage treatment. With symptoms of asthma, wheezing, coughing, shortness of breath, difficulty breathing, chest tightness. With anaphylaxis, you'll see itchiness, redness of the face, swelling of the face and tongue. Remember, that's called angioedema. Airway trouble breathing, swallowing, or speaking. Stomach would have abdominal pain, vomiting, diarrhea, nausea, or total. So that's over here. Total hives, rash, itchiness, swelling, weakness, pallor, sense of doom, loss of consciousness. So again, our treatments, a lot of these are going to be the same. Anaphylaxis, where we're still going to do epinephrine, we're still going to give solumedrol as a steroid. They work pretty well. And because we're talking about corticosteroids in this, what routes of administration can dexamethasone be given?
IVIO.
I heard IVIO.
IM?
Intramuscular. There's one more.
PO.
PO. The liquid form PO. That's the only corticosteroid that we carry that we can give oral is dexamethasone, and it's great for kids. So, PO Dex. I almost gave someone to a 3-year-old with wheezing the other day, but the mother decided she wanted to go by POV instead to the hospital. Chronic bronchitis. Obviously, bronchi become filled with excessive mucus, and the alveoli are not affected now at this point. So with chronic bronchitis, we got to make sure we can help open up these airways. Again, diffusion of gas remains relatively normal. Patients will develop low oxygen pressures, low PO2, and hypoventilation. Hypoventilation then leads to high levels of carbon dioxide and low levels of oxygen. If you had a patient with high levels of carbon dioxide, what would you see for an end-tidal reader? Would it be high or low?
High.
I missed that one. Sorry.
High.
High. Right? So how can we fix this problem?
High levels of oxygen.
Right. And what can we do? Let's say the patient's on a ventilator and you start seeing high end tidal. What can we do to help blow off that gas?
Check the IFO, make sure your percentage of oxygen is high enough, and two, may increase the respiratory rate.
Increase the respiratory rate is one other thing that we can also do to help with that.
The PEEP,
You can increase PEEP, but we don't want to go too high. How else can we help oxygenate the lungs?
increase oxygen.
And increase your I time. So your inspiratory time, breath being delivered over a certain amount of time. We normally run at a 0.9 or 1. Increase that to like 1.5, and your breath is being delivered a little bit longer, and that can help alleviate some of this as well. Help oxygenate. And also, if you have a patient on the vent and they have higher end tidal and lower oxygen saturation, sometimes repositioning the patient can also help too. Emphysema results from a pathological change in the lung. So permanent abnormal enlargement of the airspace beyond terminal bronchioles. You have destruction of the alveoli, as you can see in the picture here, along with collapse of different bronchioles as well. What's another sign that you can see a patient has emphysema? Not a symptom, but a sign, something that you can see.
Barrel chest.
Barrel chest, increase AP diameter of the chest. Exactly. So some patients in emphysema, obviously patients have some resistance to airflow primarily on exhalation. So they have a hyperexpansion caused by air trapped in the alveoli. So breathing becomes an active process. These patients here will do phenomenal on BiPAP. CPAP works, but I'm a big supporter of bilevel pressures on these patients. We start getting blood formations, CO2 retention, potential worsening with CPAP. Okay, that's why they recommend BiPAP for these patients, and risk of a pneumothorax for interior airway pressures. So if we place a patient on CPAP and we're putting the PEEP up to 15, right, that has potential to actually cause a pneumothorax. So we can keep the PEEP lower, but have inspiratory pressure for your I pressure versus your E pressures coming out, expiratory pressure. This will be better for these emphysemic patients. That's why you usually see them. They'll usually start like at a 10/5 or a 12/5, IPAP 12, EPAP 5. And then they may increase it to like 14/7 or 14/8 based on your pressures for these patients. There is a protocol in your protocol manual, your books, or your phone that actually gives you BiPAP settings that you can utilize for these patients. All right, so any questions on the respiratory review?
Yeah, what was the bleb?
I gotta go back. Hold on. And now my computer is frozen. Stand by, I'm always hungry. A little too fast. Why is it not working? Hold on, stand by. So the blood formation, I'm trying to see if I can bring up a picture for you guys to see it to make a little bit more sense for you. So blebs are protrusions of the cell membrane, and they're a result of trying to make it so it's not too complicated here. So it can cause transient detachment of the cell membrane from the actin cortex or a rupture of the actin cortex itself. Then cortisol streams out of the blood cells and infiltrates a newly formed bleb. I want to show you guys a picture of it, but I would actually stop my presentation so you can actually see what it looks like. Stand by. That did not work like I wanted it to. Let's see. Let me bring it up on here really quick. I really want you guys to actually see it. I can talk about it, and then it won't make any sense. Ooh, let me click that one there. So can you guys see the screen still?
Yes.
Okay. So that's kind of a complicated photo. Stand by. I'm trying to find a picture that would make more sense. It doesn't get
I
too.
think it makes sense now by even looking at the one you have up.
Okay, is that a little bit better?
Yeah.
Oh, stand by. There we go. So the bleb assembly. So local membrane detachment. So as you can see, initiation starts here and forms these blebs. As you can see here. So that's what's happening inside the lung.
We're not seeing the picture or anything.
Oh, okay. So what are you guys seeing now? You guys see my presentation?
I saw what you have.
Like your YouTube channel thing with video processing.
Okay. All right. We'll go to the next one here. That's fun. All right, so CPAP, continuous positive airway pressure. So the use of CPAP pre-hospital reduces the need for intubation by 30% and mortality by 20%, right? That's huge, right? That's a huge thing for us, is to be able to reduce intubation, right? Some people that get intubated, sometimes they don't come off of it, all right? So CPAP, like I mentioned, is that crutch that's going to help keep you from being intubated. And this is the 30%, reduces intubation by 30% with this. CPAP is a non-invasive ventilation. It's non-invasive. Continues O2 delivery at a set positive pressure through the respiratory cycle. Positive pressure then pushes air into the chest, overcomes airway resistance. I'm just turning that off. That's it. All right. So, excuse me. We have the ability to use a bag valve mask or demand valves, intubation, mechanical ventilation, and CPAP. These are all things that provide positive pressure. So at the EMT level for the longest time, all we had was a BVM. Now they brought CPAP down to the EMT level. Well, they've had it for New Hampshire for a while. And Maine just put it in the protocols set that just came out December 1st. And Massachusetts also has it as well. The effects of CPAP obviously increases functional residual capacity, increases alveolar surface area available for gas exchange, increases oxygen diffusion across alveolar membranes, it reduces the work of breathing. So the point of CPAP is to reduce the work of breathing so they don't have to breathe as hard and oxygenate the system. By doing so with CPAP, if you guys are all to take a deep breath in and then exhale with your mouth wide open, you notice that there's no pressure. Okay. If you were to take a deep breath in and purse your lips and then breathe out or exhale, you'd notice it takes a little bit longer for that exhalation to finish. That's providing PEEP. So when you have patients that are having COPD exacerbation, a lot of times you'll see them tripoding, there'll be accessory muscle use, and you'll see them having a pursed lip breathing. They're trying to create more PEEP than our body normally provides. So where is our normal PEEP provided from? Like what creates PEEP in our system on a normal day? What helped?
Sandwich.
What was that?
An Italian sandwich.
An Italian, I like it. So if you look to the glottic opening, so picture the airway, right? You have your glottic opening and your cords. We look for the cords when we intubate, okay? Those cords actually create PEEP when you exhale. So you have a cord paralysis, okay, and they're stuck open, you're not going to be able to breathe very well at all because you have no PEEP whatsoever. Those cords are what provides PEEP to our system. Okay, so you got to think about this when you're going in to intubate somebody. If you hit those cords too many times and it causes paralysis and they stay open, what do you think's going to happen to that patient when they're breathing on their own? They're not going to be able to create any of their own PEEP. Which is why it's important that when you see the cords and you go through, you want to make sure you get it the first shot. So once you've poked and prodded at it, you may lose that ability for the patient to be able to create their own PEEP anymore. So how CPAP actually works? It maintains constant level of airway pressure. It keeps the alveoli open for asthmatics and COPD. It moves fluids into the vasculature for pulmonary edema. It helps improve that gas exchange and buys time for medication to actually start working. So remember how I mentioned before, it's that crutch. This is the crutch I'm talking about. It helps keep that airway open and let medications actually start working. That's why I'm a firm believer of getting CPAP done in the house before you get outside so you can start the inline neb and let that medication start to work. All right. Like I said, whether you're 20 minutes from a hospital or 5 minutes from a hospital, if I was the one having respiratory distress, I wouldn't want you to wait to put me on a stair chair to bring me outside. That takes 5 minutes. I want you to fix my breathing now. So CPAP in the house, it doesn't take more than 30 seconds to put it on, as long as they're not hyperventilating and panicking, and they can maintain their own. Or all else fails, put it in their hand and say, you put it up to your own face and hold it. Once they realize, oh my God, this is actually working, so it's almost instantaneous when it starts working, they'll start seeing that change. Then they'll start to calm their breathing down. And then you can actually apply it to their face by using the head net, the net that comes with it, right? Sometimes just the patient learning on their own will help make a huge difference. So utilize it. Indications for severe respiratory distress and respiratory failure. Is there any accessory muscle use, persistent hypoxia despite appropriate aggressive oxygen therapy, marked increased work of breathing, or inability to speak full sentences? And these are also things you want to put in your narrative as well when you ask these questions. These are good respiratory questions. And differentiate the difference between pulmonary edema versus other respiratory disorders because our treatments are going to be different. So you have to make sure you understand lung sounds. And if you hear wheezing with no fluids, okay, bilateral fluids, that's perfectly fine. But you may hear some rhonchi and confuse that with rales or the crackles. But if you have, and most of the time when you have pneumonia, usually it's lobe specific on one side versus the other. So if you hear some kind of fluid build up on one side, but the other side sounds clear, maybe CPAP and other respiratory meds like Solumedrol and Duonevs that might work better versus giving someone that has crackles on both sides and fluids filling up and then maybe a little bit of pink frothy sputum. Those patients need nitrates. They don't need albuterol. So you got to differentiate the difference between the two before we start administering medications. But CPAP, you can't go wrong because you can put CPAP or BiPAP on either patient. So help, like I mentioned before, there's your crutch to hold that airway open while you start getting medications on board and make sure you're giving them the right meds. And at the paramedic level, there's nothing wrong with going right to nitro drip versus nitro tablets. Nitro drips work phenomenal and they're easier to control and regulate versus just popping tablets as well. Some contraindications: respiratory rate of less than 10 breaths a minute, Systolic blood pressure of 100, because with the CPAP being applied, that can also cause barotrauma as well. So you got to be careful with that, but it can also decrease your blood pressure. Confusion and the inability to understand directions or cooperate with the application of CPAP. If they are that altered and they can't breathe, these are the patients that need to be RSI'd because they can no longer maintain their own airway with CPAP. History of pneumothorax or recent tracheobronchial surgery. Active nausea or vomiting, right, despite antiemetic therapy by paramedics. 2 medications that we normally carry. We don't really carry Compazine on trucks. It's available to us. We just don't have it on the ambulances here. We do carry metoclopramide and we do carry ondansetron. Ondansetron, Zofran, is phenomenal for nausea. Active vomiting, Reglan does the trick almost every time. We cannot mix the two, so pick one or the other and which way you want to go. And we can repeat each one as well. CPAP is not a mechanical ventilator. Tight mask seal can create claustrophobic response. This is what I was talking about before by utilizing Ativan or some Versed to help with the anxiety. The CPAP is also powered by an onboard oxygen supply as well, so you got to make sure you have enough oxygen in your tanks to get there. Right. So if you are putting it on in the house, put it on the house, then start getting ready to transport. Don't sit there and get everything else done with it. Right, like putting your IV and pushing all your meds. Crutch them, get them out to the ambulance. You get them on your onboard system, then finish up your treatments and then get going. Right. Understand that when you bring somebody to emergency department, this is very important to pay attention to. If we're not treating patients because the hospital is 5 minutes down the road, keep in mind that they have to be triaged, evaluated by a nurse, chart has to go up, physician has to come in, orders have to be given, meds have to be drawn, then meds get administered. Or because we have state protocols, we can do it right then and there and start that respiratory treatment right away. Okay, you got to consider how long it takes in an ER for a patient to be seen by a doctor, especially nowadays with the amount of COVID patients that are coming in there and the ERs being so full. They might only have one physician on. It could be 15 minutes before a physician comes into the room. And nurses only have standing orders for certain medications that they could administer. And MAG is not one of them. That has to be done, and Solu-Medrol isn't either. Those have to be done ordered by a physician. All right, so oxygen demand with these things here, it utilizes a lot of oxygen. That's why BiPAP is better regulated. We can use a lower percentage utilizing vents. The only good thing by utilizing a ventilator for CPAP is you can actually adjust the FiO2 to a lower oxygen percentage. Even with CPAP and or BiPAP, the drawback, I lost my train of thought. So the drawback with the portable ones, the disposable, is we cannot adjust it. Everything's at 100% FiO2. All right. So here are your protocols here. I did update these though a little bit. It doesn't have CPAP. So CPAP for the EMT level. And then obviously duoneb albuterol for the A. And then at the medic level, we have the ability to give either Dex or methylprednisolone, Solu-Medrol. Then we have epinephrine and mag sulfate, 2 grams in 100. Right. So you can also do epi. IM is preferred in the thigh. You can do 0.3 milligrams. For patients who do not respond to treatments or improving respiratory failure, you can consider BiPAP as well. So if you have ventilators on your truck, I would write to BiPAP right off the bat. I wouldn't even bother with CPAP. The BiPAP just works 10 times better. For CHF, the same thing with EMTs. Obviously, patients own nitro every 5 minutes, as long as BP is greater than 140 systolic. We get into the AEMT. We can treat with sublingual nitro or sprays if needed. And then going into the paramedic level where we start the nitro drips, depending on patient's blood pressure. Now, patients with a blood pressure of 200 systolic, we want to start at 200 mics. Again, that's kind of aggressive. Just remember that we can drop blood pressures quickly with these, so pay attention. The 2 lines are recommended when giving IV nitroglycerin and it has to be done through an infusion pump. So to kind of mention to that as well, you do not need nitro tubing. for the short distances and time frames that we'll be utilizing nitro in the field. And I can tell you for sure that working in the ER for as long as I have, not once do we ever use nitro tubing for any of our drips. It was all regular tubing for them, because for the short amount of time they're going to be on that, it didn't make a difference. So we can utilize regular drip sets for those. There is a drowning submersion protocol as well, where they can utilize CPAP for patients' own respiratory effort. For unconscious patients, consider early intubation. There is a hypothermia chart here as well. One of the things they recommend for hypothermia, though, and this is kind of a different topic for hypothermic patients, but if you look down here, hypothermia patients, low levels of end-tidal, sorry, one above it. Patients with stage 3 or stage 4 hypothermia may benefit from treatment at a facility capable of ECMO, right, or cardiopulmonary bypass. Consider air medical transport. So you got a patient in stage 3 or stage 4. There's only 2 ECMO centers in the state of New Hampshire, and that's Dartmouth and Portsmouth. They're the only 2. Now, Maine Med has it. They didn't mention Maine Hospital. So anywhere in the valley, Maine Medical Center also has an ECMO center as well. Portsmouth, though, is a lot closer. Okay, so you can utilize Portsmouth Hospital. But, you know, if you're in other areas of the state, air medical transport may be the best option to get them to an ECMO center. They're saying that they're seeing a lot higher survival rates because of ECMO with these hypothermic patients. This is your CPAP. Remember, I got to update this as well. This is older because now you have EMT level in this. And this is your bi-level, excuse me, your BiPAP settings here. So 5.3. So they base it on height and weight. They also want you to consider, this is more for the procedures for intubation down here. But your IPAP setting maintains sufficient support, generate tidal volume between 6 to 8 mLs per kilo, which you'll be able to see, by the way, on your ventilators. It tells you what your tidal volume is based on that when they're breathing out. Not to exceed up to 20. So see the chart below. So I'll go over the chart down here. Again, for those who have ventilators on their trucks, here, I will personally go over with you guys once we get them down here and how to utilize BiPAP in the field in our settings then. So, and Scott, I'm more than willing to help out with you guys as well up north, whatever needs to happen, because I'm a firm believer in this stuff. Let's see. So obviously, pre-hospital studies have proven that effectiveness in CPAP in treating patients with severe respiratory distress, regardless of the disease process. It works. It helps. All right. So let me disconnect from this lecture here really quick.